Hi, my name is Donna Edwards, and in this presentation, we'll be discussing implementing tobacco cessation treatments for individuals with serious mental illnesses. Why implement tobacco cessation treatments for individuals with serious mental illnesses? SMI. Individuals with SMI die several years compared to those without mental illnesses, and smoking is a major contribution factor. Quitting tobacco use would simultaneously reduce high rates of morbidity and mortality due to cancers, cardiovascular, and respiratory disease among individuals with SMI. Quitting smoking has been found to have mental health benefits such as reduction in depression, anxiety, and stress, as well as increased positive mood and quality of life. Can interfere with psychiatric treatments in part because of some components of tobacco smoke accelerate the metabolism of most antipsychotic medications. As a result, therapeutic levels of drugs established in smoke-free hospitals become sub-therapeutic when clients resume smoking on discharge. Quitting smoking can increase clients' sense of mastery, helping them focus on taking additional steps towards positive lifestyle. Call to action. Do you work in a mental health treatment facility such as a residential treatment program or an outpatient treatment program? Do you want to take action to reduce the use of tobacco products and tobacco-related disease among your clients with SMI? If you answered yes to these two questions, this presentation can help you implement tobacco cessation programs for individuals with SMI. The objective will require staff time and resources. It may also require a culture shift within your agency. It is worth the investment, however, because of the clear benefits that will accrue to your clients, their families, and your staff. Here is an overview of the problem. Cigarette smoking is widespread among individuals with SMI. The prevalence of smoking among individuals with SMI is nearly twice that of the general U.S. population, 35.5% versus 18.6%. Individuals with SMI smoke more cigarettes more intensely, have a greater nicotine dependence, and experience greater withdrawal symptoms when attempting to quit. Smoking shortens life expectancy among persons with SMI. Individuals with SMI die several years earlier. On average, compared to individuals without mental illness. And smoking is a major contributing factor. 50% of deaths among individuals with SMI are due to cardiovascular conditions, cancers, respiratory diseases, conditions that can be caused and or worsened by smoking. Less than half of all mental health treatment facilities offer tobacco cessation services. In 2017, only 39% of mental health treatment facilities in the United States provided cessation counseling. Only about 25% of these facilities offered nicotine replacement therapy and or other tobacco cessation medications. Furthermore, only one-half of mental health treatment facilities had smoke-free policies, both inside and outside their facilities. Providing clients who smoke with cessation counseling and medications significantly increase their odds of quitting, especially when they are provided together. Individuals with SMI who want to quit can be successful in quitting. Research confirms that individuals with SMI who smoke are as likely as the general population who want to quit smoking. and are able to quit when tailored tobacco cessation intervention is integrated into their mental health treatment. Individuals with SMI who smoke are as ready to quit as those without SMI and can do so without jeopardizing their mental health recovery. Adverse impact of tobacco use on mental health. Heavy smoking is a significant risk factor for major depression. Depression is twice as common in smokers compared to non-smokers and 4 times as common in heavy smokers. In fact, heavy smokers has been reported to predict an onset of major depression. Daily tobacco use is associated with an increased risk of psychosis and an earlier age of onset of psychotic illness. The overall prevalence of smoking in individuals having their first episode of psychosis was 3 times higher compared to non-smokers. Individuals with first episode psychosis have high prevalence of tobacco use compared to non-smokers, having smoked approximately for 5 years on average prior to onset of psychosis, with daily smoking predicting more psychotic episodes. Tobacco use is significantly associated with increased suicidal behavior. Studies have found current smoking to be significantly associated with suicide ideation, suicide attempts, and completed suicide. In fact, longer lifetime smoking, over 40 years versus under 10 years, was associated with 2-fold higher odds of suicide. Tobacco use can interfere with psychiatric treatment. Smoking affects medication levels of several psychotropic medications. Components of tobacco smoke accelerate the metabolism of certain psychiatric medications, resulting in lower blood levels and the need for higher medication doses. This chart shows drug interactions with tobacco smoke. There are benefits of providing tobacco cessation interventions. Tobacco cessation is associated with positive mental health outcomes. A meta-analysis of 26 studies found that smoking cessation was associated with reduced depression, anxiety, and stress, as well as an improved positive mood and quality of life when compared to continuing to smoke. The meta-analysis found that the effect size are equal or larger than those of antidepressant treatments for mood and anxiety disorders. In addition, studies have shown that neither a reduction in smoking nor use of smoking cessation medications such as Versaline appear to result in a worsening psychiatric symptoms in individuals with stable treated SMI. Tobacco cessation at any age is associated with physical health benefits. Quitting smoking is one of the highest choices any smoker can make. Quitting has the following immediate and long-term benefits of quitting smoking. Within 2 weeks to 3 months of quitting, the chance of having a heart attack begins to drop. Lung function begins to improve. Within 1 to 9 months, coughing and shortness of breath decrease. Within 1 year of quitting smoking, the risk of coronary heart disease is half that of a smoker. Within 2 to 5 years, the chance of having a stroke is reduced to the same as that of a non-smoker. Within 10 years, lung cancer risk is half that of a smoker. And within 15 years, the risk of coronary heart disease is the same as those who never smoked. Of tobacco treatment. Identification, counseling, and medication are evidence-based practices to treat tobacco dependence. The combination of medication and counseling is more effective at treating tobacco use and dependence than either treatments alone. Clinicians should encourage all individuals attempting to quit to use both counseling and medication. Tobacco cessation treatment includes 5 key steps. Train all members of the healthcare team in the 5 A's model. Ask, advise, assess, assist, and arrange. For treating tobacco use and dependence, healthcare teams identify and treat every tobacco user seen in a mental health program using the 5 A's model as recommended in the Clinical Practice Guidelines Treating Tobacco Use and Dependence, developed by the Public Health Service of the Department of Health and Human Services. You want to ask about the tobacco use. Identify and document tobacco use status for every client at every visit. Advise to quit. In a clear, strong, and personalized manner, urge every tobacco user to quit. Assess willingness to make an attempt to quit. Is a client willing to make a quick attempt at this time? Assist in a quit attempt. For the client willing to make a quit attempt, offer medication and provide or refer for counseling or additional treatments to help the client quit. For clients unwilling to quit, provide interventions designed to increase future quit attempts. Example given, motivational interviewing. Arrange follow-up. For the client willing to make a quit attempt, arrange follow-up contacts, beginning with the first week after the quit date. For clients unwilling to make a quit attempt, address tobacco dependence and willingness to quit at their next clinic visit. Let's discuss the counseling. Tobacco cessation counseling can be delivered in individual, group, or telephone-based sessions. The effectiveness of the counseling is correlated with treatment intensity. When working with clients making a quit attempt, clinicians can offer practical counseling and social support as described below. Number 1, practical counseling. Problem-solving skills training can include conveying basic information. Example given, nicotine addiction, withdrawal symptoms, quitting techniques, including use of cessation medications. Clinicians can help clients identify high-risk situations, example given, triggers for smoking, and practice coping strategies for when they are in a high-risk situation. Number 2, social support delivered as a part of treatment can include encouragement and expressions of caring and concern. Example given, expressing belief in the client's ability to quit. Acknowledge the difficulty of quitting, and noting that support is available from others through cessation medications. Telephone quit line counseling is effective with diverse population and has a broad reach. All states have quit lines and are staffed by trained counselors that can help smokers quit. This toll-free telephone service can be reached at 1-800-QUIT-NOW. That is 1-800-784-8669. For veterans, support is available at 1-855-QUIT-VET. That is 1-855-784-8838. For Hispanic Americans, support is available at 1-855-DELEJO-YA. And for Asian Americans, support is available at http://www.asiansmokers.quitline.org/smokefree.gov. Offers tips, plans, text messaging programs, apps for 24/7 support, and other ways to get ready to quit to be smoke-free for good. Tailored information and resources are offered for smokers who are pregnant, veterans, teens, Spanish speakers, or older adults. These resources can be found at www.smokefree.gov. Motivational interviewing can be found useful for smokers who are not ready to quit or who are ambivalent about quitting. Clinicians should be advised all tobacco users can quit and assess as clients' willingness to make their quit attempt. For clients who are not ready to make a quit attempt, clinicians can use MI techniques to encourage quitting tobacco use. This supportive and non-judgmental approach is based on engaging the client, focusing on mutually agreed on agendas that promotes change, evoking client motivation for change, and developing a change plan. MI is a directed, person-centered counseling style that is effective in helping clients change their substance use behaviors. The core MI skills of asking open questions, affirming, using reflective listening, and summarizing can enhance client motivation and readiness to change. Counselor empathy, which is shown through reflective listening and evoking change talk, is another important element of MI effectiveness and is associated with positive client outcomes. MI has been adopted for use in beliefs and interventions and across a wide range of clinical settings and client population. Smoking cessation medications. There are 7 FDA-approved medications for smoking cessation. 5 are nicotine replacement therapies: nicotine patch over-the-counter, nicotine gum over-the-counter, nicotine lozenge over-the-counter, nicotine nasal spray prescription, nicotine inhaler prescription. 2 are non-nicotine medications: bupropion, Zyban by prescription only, and Vericillin, Chantix by prescription only. Healthcare providers should check prescription labeling information of the smoking cessation drugs available at Drugs at FDA to determine if there are any potential drug interactions. Example given: some patients using Vericillin experience a decreased tolerance to alcohol or possible risk for specific populations. Example given: women who are pregnant or breastfeeding, including with diabetes, heart disease, asthma, or stomach ulcers. Healthcare providers should also review the product labels for drug warnings. For details, visit Drugs at FDA. Now let's discuss implementation of a drug-free environment. Having a tobacco-free workplace. A, where all tobacco products, cigarettes, cigars, smokeless tobacco, chewing tobacco, e-cigarettes are prohibited. B, where smoking is prohibited on all facility premises, indoors and outside. And C, where the policies apply to clients, visitors, and employees sends the message to staff and clients that the organization's leadership and administrators are committed to the health and wellness to everyone. It also creates a supportive environment for those who want to stop using tobacco. 2 steps in establishing a tobacco-free workplace are: Number 1, once you have implemented tobacco cessation programs, establish the policies and procedures required in a tobacco-free workplace. Tobacco-free workplace policies should be clear and concise. They should clearly explain tobacco restrictions and how the policies will be enforced. Communicate the policies to all affected parties. The tobacco-free workplace policies should be announced and communicated to all substance abuse treatment program staff, clients, and volunteers, as well as to visitors to the facility grounds. While many people fear that implementing a tobacco-free environment will be very difficult, the literature suggests that these fears are largely unfounded. In fact, the subsequent outcomes after implementation are typically quite favorable for both staff and clients. Tobacco cessation integration tips. SAMHSA recommends that mental health facilities adopt policies for tobacco-free facilities as grounds to integrate tobacco treatment into the care they provide. The following tips can help to ensure successful integration of these recommendations. Obtain the commitment of senior leadership and management. Having the commitment and support of the board of directors and senior management is a paramount in successfully implementing a tobacco cessation program and a tobacco-free policy. Guaranteeing the support prior to the start of the program is essential to promote and implement the program within the organization and the community. Identify a program champion. This individual should be dedicated staff member who can coordinate your agency's tobacco cessation and tobacco-free policy efforts. Create a planning committee that involves staff. This committee will develop written policies, procedures, and an implementation plan. It should include representation from staff members across the organization and across disciplines in order to address their concerns and leverage their clinical experience. Including medical team members is important so that medications for tobacco cessation can be made available as a part of treatment. The committee can also troubleshoot issues that arise during implementation. Implement an office-wide documentation system. This ensures that tobacco use status is queried and documented for every client at every clinic visit. Expand vital signs documentation to include tobacco use. By taking the client's vital signs, blood pressure, pulse, weight, temperature, respiratory rate, tobacco use. Assist staff members who want to quit tobacco use. Look for opportunities to celebrate success. Set a start date for when the new policies will go into effect. The date should be far enough in advance to allow for staff training, raising awareness about the new initiative, offering and promoting cessation services, incorporating new treatment protocols into records, obtaining tobacco-free signage, and other necessary preparations. However, the start date should not be so far in the future that momentum is lost or that commitment to implementing the new policies can wane. Roll out awareness activities before and after the start date. Use a variety of information channels, example given, agency emails, staff meetings, signage, client brochures, social media, to ensure to share information on new policies, procedures, and related items. Prior to start date of tobacco-free policy, implement a series of countdown activities to promote the changes and build awareness. Progress. Measure progress against objective by collecting data on tobacco use screening, cessation treatment utilization, and tobacco use status at discharge, as well as compliance with the tobacco-free policy. Ensure collaboration with all members of an individual care team. For certain medications, which may include psychotropic medications, medications to treat opiate use disorder, or some medications for physical health conditions, the levels of medication in the bloodstream will shift as the individual reduces their tobacco use. It is important that all providers, including substance abuse providers, psychiatrists, and primary care providers, are aware that the client plans to quit using tobacco so that they can support their cessation efforts and monitor the need for change in doses and treatments. In conclusion, tobacco use is widespread among individuals with SMI, and the high prevalence of tobacco-related morbidity among them is well documented. Research shows that individuals with SMI who smoke are as interested in quitting as those without SMI and can do so without jeopardizing their mental health recovery. Quitting smoking is one of the most important choices that anyone can take to improve their health, and is beneficial for both physical and mental health. Furthermore, quitting smoking can have a broader positive influence on individuals with SMI. As they learn effective skills and techniques for smoking cessation, their sense of mastery and self-efficacy to make those healthy lifestyle changes can increase as well. Tobacco cessation treatment should be an integral part of treating individuals with SMI. There is a critical need to engage mental health program directors and clinicians in efforts to increase access to evidence-based tobacco treatment for these individuals. For the numerous reasons cited within this guide, SAMHSA recommends the adoption of tobacco-free facilities, grounds policies, and integration of tobacco cessation treatment into the care provided to clients with SMI who smoke or use tobacco products.